Good afternoon, everybody. Sorry I was late this afternoon. So my topic is on retinal non-perfusion, another emerging area of research. So these are my disclosures. So far, our understanding on retinal non-perfusion is based on retinal imaging. So we moved on from color photographs, 7-fuse to ultra-wide field, then to angiogram, and then OCT-A, OCT, and very recently AIOS2025 as well. Are we there yet? Not. So I think it is really an emerging field. So based on color photograph, if you see these features, clearly we will estimate, at least in our heads, that this patient has retinal non-perfusion. But color photograph by itself cannot assess retinal non-perfusion. And we all know from all the DRSS studies that the higher the DRSS score, the more likely the patient is going to have increasing retinal non-perfusion. And then recently, Paula, Silva, etc., have published quite significantly on the predominantly peripheral lesions on ultra-wide field imaging, again suggesting that they are a sign of ischemia. So if patients have PPL, they have 4.7-fold increased risk of developing PDR because it is a surrogate for peripheral ischemia. Angiogram, this work starts published in 1981, so 25 years ago. The Japanese group already knew that mid-peripheral retina is more prone for retinal non-perfusion than the posterior retina. So they are the first to get involved. But retinal non-perfusion progresses towards the center. So it is more pronounced. The more retinal non-perfusion, the more likely the patient is going to develop NVI and NVD. So in order of retinal non-perfusion, degree of retinal non-perfusion, you may get NVE, progress to NVD, then to NVI and NVG. So we did some work on, because we have ultra-wide field, we tried to look at all the retinal non-perfusion and correlate it to the diabetic retinopathy severity, and we find that if they have peripheral non-perfusion, they are likely to develop NVE. But if the non-perfusion is more in the center or it progresses to the center, those patients are likely to have NVD. So that's a generalized sign of retinal non-perfusion. So it's almost like retinal non-perfusion phenotypes. Topographically, we know like peripheral non-perfusion is defined as more than 6 diameters from the optic disc, and then mid-peripheral is 6 to 4, and then central is 4 disc diameters around the posterior pole. But generalized is all through. And the peripheral one is the slowest to progress and is the least common. The mid-peripheral is the most common and the fastest to progress to NV. And the generalized one suggests that the patient is likely to be due to poor control of diabetes and likely to develop NVD as well. So we also looked at the total retinal non-perfusion that is likely in a patient with PDR, and this accuracy test suggests that we need about 100 disc areas of retinal non-perfusion for an eye to develop new vessel disc. This is the DRCR protocol AA. They produce the same results, but of course in a larger population and in a trial. And they also showed cumulative proportion of disease worsening or progression to PDR is more in eyes with highest non-perfusion. You can see the Kaplan-Meier graph. So at this point, we have to credit Ramin Tadayoni because he tried to do capillary non-perfusion work on OCT-A. And he found a mismatch between retinal non-perfusion on OCT-A versus the presence of PDR. And he suggested that there is significant overlap of non-perfusion index. Non-perfusion index is defined as the total area of non-perfusion divided by the total gradable retina. And he found that there is significant overlap between severe NPDR eyes and PDR eyes. So, and the reason for this disparity, he suggested, was probably because there is more peripheral non-perfusion that is not measured in OCT-A. So it's actually a device problem rather than our understanding of the knowledge. And we are hoping this EVIRET study, the followers of Tadayone group will come up with many more papers because they are the ones with the largest collection of OCTA images in studying retinal non-perfusion. This is the quantitative metrics of fluorescent of capillary non-perfusion. So this is Justice Eller's work. Previously, we only said, as we did, we just say central non-perfusion, peripheral, combined, generalized. But now they are able with AI, they are able to measure the ischemia, give quantitative measurement, and also do microaneurysm turnover and leakage. So leakage is quite new for us in diabetic retinopathy. Peripheral retina, I mean, we have always seen leakage, but never put a figure onto that. And Justice Eller's work suggests that peripheral leakage around the retina is as strong as indicator as capillary non-perfusion. So now we have 3 markers of capillary non-perfusion, i.e. ischemia or NPI, or count the total area, microaneurysm turnover, and now NPL or leakage. Now we know that ranibizumab and many other anti-VEGF agents improve the DRSS score in about 30 to 50% of patients. But this is the Clarity trial we did. Despite all the improvement we see, cosmetic improvement, all the new vessels disappear, PDR patients become NPDR, all this magical treatment, the non-perfusion doesn't change with anti-VEGF. So actually, if you see very carefully, the non-perfusion actually increases as the disease progresses. So anti-VEGF have no effect on the non-perfusion. And also, we know the DRCR protocol S suggests that even when patients are on ranibizumab, there is visual field loss, which means the capillary non-perfusion is still progressing, causing the field loss. Usually we, before the era of ranibizumab anti-VEGF agents, we had PRP only. So we attributed all field loss to PRP. But this study was really good in that it showed us that whether you treat the ranibizumab or you censor the patient who had PRP, they still develop visual field loss as a result of retinal non-perfusion. So the disease progresses. Next few minutes, I will describe foveal avascular zone and macular ischemia. So we all, from the days of fluorescent angiogram, we all know the ETDRS paper 10 that showed us how to grade diabetic macular ischemia. So if there is more than half the foveal avascular zone that is enlarged and distorted, we know that we call them foveal diabetic macular ischemia. But we also know that we see a lot of patients with enlarged, irregular foveal avascular zone, but the visual acuity remains normal, right? We have seen all these patients. So this is Amani Fauzi's work. So she showed that actually it's the deep capillary plexus perivenular area of non-perfusion is the first sign of capillary non-perfusion, even before the patient develops the first microaneurysm in the retina. So actually the drop-off is quite early, and therefore if you're to do preventive treatment, it has to be really, really early. I know we can't do anti-VEGF or intravitreal injections as preventive therapy, but if you have drugs, oral drugs or topical drugs, maybe this is the time you have to start the treatment. This is some of our work where we're trying to double on OCTA as well, and we clearly show that with increasing severity of diabetic retinopathy, we see higher standard deviations of capillary non-perfusion, both in the deep and the superficial layer, more so in the deep. Now we did a follow-up study, so 12-month study on patients with natural history diabetic macular edema in PRP-treated PDR eyes. We just wanted to see how the foveal avascular zone changes over 12 months. And you can see here we had 4 visits over the 12 months. There was no change in any of the OCTA features in the 12 months. Okay, so the true worsening of foveal avascular zone beyond the margin of measurement error was less than 10%. So this is very tricky, because if you are going to do a trial to look at changes in foveal avascular zone, it can't be a small trial, right? And a short trial, because at 52 weeks, nothing happens even if no treatment is given. We also looked at all the changes in visual function and vascular metrics over the 12 months. We had several parameters, visual function as well as structural changes. And actually, all of them showed deterioration, but the only significant one was still foveal avascular area. So despite all the new terminologies we have learned about superficial deep vascular plexus, their density, their tortuosity, fractal analysis, we still end up saying foveal avascular zone enlargement is actually the best metric to look for in DMI patients. But despite this enlargement, we saw no visual function changes, no BCVA change, no contrast sensitivity change, no microperimetry change. So clearly, any clinical trial in this area should run more than 12 months. So there are OCT phenotypes in diabetic macular edema. So if you have no drill and no EZ loss as the reference, that means they're the good eyes with enlarged foveal avascular zone. If you have drill alone with no EZ loss, the patient is going to lose at least one line of vision compared to normal, compared to those with enlarged FAS. If EZ loss alone is considered, they only lose very little vision. But if drill and EZ loss are there, then they lose 2 lines of vision. So really, the structural changes drive visual acuity. So this is the anti-SEMA3A pathway that is being experimented now with Boehringer Ingelheim, looking at whether this axonal guidance molecule, that is, it inhibits endothelial cell addition, and therefore it can grow into areas of capillary non-perfusion to try and reperfuse that area. That is the fundamental mechanism of action. There have been the Hornbill trial that used this on previously treated patients with PRP but had enlarged FAS. They seem to think that there is some minimal action there. They saw a few vessels in the foveal avascular margin. They believe that is a good sign, but for me, it may be even an OCTA repeat that shows a new vessel that appeared and disappeared, because foveal avascular zone on OCTA is really tough. And now they're running the Crimson study, which is patients with moderately severe to severe non-proliferative diabetic retinopathy with enlarged FAS, and giving these as intravitreal injection of semaphorine 3A to see whether the foveal avascular zone can be modified. So there's several unanswered questions in this field. For example, we don't know the threshold of retinal non-perfusion required for neuronal damage. We also don't know why the discrepancy between DRSS and capillary non-perfusion. Probably it may be due to the anti-VEGF just working on the leukostasis part, but no effect on anti-VEGF and non-perfusion. The topography of retinal non-perfusion seems to be very important, both in the cross-section as well as deep, superficial and deep vascular plexus. Now, to do a trial in this area is really, really difficult because A, we don't know how to measure retinal non-perfusion. Secondly, we don't know what is clinically benefiting the patients with a change in retinal non-perfusion. Unless they affect the visual acuity, why do patients need to have all these injections? So these are all unanswered questions. Thank you very much.
It's an excellent understanding about the ischemia of in the NPDR. It's a pretty interesting studies what you brought it out. Any question? Yeah, please go ahead. Just use the mic. I have a question. I'll ask you later.
I am basically a glaucoma surgeon, so whenever we get NBG, the commonest procedure that we do among the commonest ones is valve which we put. So when we put a valve, the eye works like magic. All the NVE goes away, NVI goes away, and despite the patient being diabetic, he may live 10 years, 15 years. I have huge number of patients where we once put the valve, the NV just disappears. NVI doesn't come back. Very rare that I see it coming back.
Without PRP?
PRP is given. That is taken for
I probably think the highest VEGF is in the aqueous. So I think when you manipulate your aqueous chamber, it does release all the VEGF. I think that might be the reason. I don't understand, I don't know of any other reason. So hypoxic drive is definitely decreased.
I just a quick question about it, that when we did the study about the non-perfused areas, have you considered the pericyte loss into consideration while you're calculating it?
No, I will tell you OCTA by itself is extremely difficult. I mean,
yeah, I understood, okay.
So to do a pericyte, I mean, we are still far off from that.
Okay, okay.
Yeah. AO, like Amani Fauzi is doing quite a lot of work on AO. I think they are able to see the pericytes. I think it should be very, very specialized imaging.
Thank you. Thank you. Thanks a lot.
Thank you very much, Professor Sobha, SIVAPRASAD. So wonderful. We have a great session, a lot of discussion. That's why we're running a bit late, right? Sorry about that. So we have to release the room. But then for our audiences and colleagues still interested in emerging research in ophthalmology, we can still have more discussion outside. So release the hall. Thank you.